Auzubillahiminash-shaytanir-rajim. Bismillahir-rahmanir-rahim. Ladies and gentlemen, very good evening and good morning at the west side. I, Dr. Hina Siddiqui, and my colleague, Ms. Khazima at Comstech, would like to welcome you all in the Comstech Distinguished Speaker Series. And we are privileged that eminent speakers have delivered various lectures in this series. And today we have come up with another eminent speaker. So without taking much of your time, I would like to request all of you to kindly keep your mics on mute mode so that we can hear our speaker clearly and nicely. And I would like to hand over it to my colleague Khazima. She will introduce you with the Comstech and its initiative.
Assalamu alaikum, everybody. Thank you, Dr. Hina. Thank you very much for joining us today, everybody. I welcome you to another exciting lecture by one of the very distinguished scholars arranged by Comstech. Comstech is the Ministerial Standing Committee on Science and Technology of the member OIC countries. Comstech was established in 1981 and we operate in 57 member OIC countries. Our main mandate is to enhance scientific cooperation among the 57 member OIC countries, and ultimate aim is to nourish a scientific culture among these member OIC countries as a major contributor towards the socio-economic uplift of these member OIC countries. With this, I will among these member OIC countries towards Coordinated General Comstech and iccbs to welcome and introduce our guest speaker today. Over to you, sir.
Good evening, ladies and gentlemen. This is a wonderful honor for me to introduce someone I always cherish and appreciate. The contribution of Professor Dr. Zulfikar Guta is very well known. He's one of the most profound, the person who has made profound contributions in the field of healthcare research in Pakistan and globally. Professor Dr. Guta is the Distinguished University Professor and founding director of the Institute for Global Health and Development and the Center of Excellence in Women and Child Health at our very premier institution called Khan University of Science. He also holds the Robert Harding Inaugural Chair in Global Child Health at the Hospital for Sick Children, Toronto, Canada, and he's the co-director of the Sick Kids Center for Global Health. These are unique joint appointments which actually indicate the stature and contribution of Professor Zulfikar Ali Guta. He also holds adjunct professorship at several leading universities all around the globe. If I start reading all of the titles, this would take a lot of time, but let me just tell you what, the major salient features of Professor Guta's contribution in the field of healthcare. He is a designated distinguished national professor of Government of Pakistan, and he was the founding chair of National Research Ethics Committee of Government of Pakistan during 2003 to 2014. Dr. Guta was a member of independent ethics expert review group appointed by the UN Secretary General for Okay, so Dr. Guta has actually worked with many international organizations, including World Health Organization and the Secretariat based at the Hospital for Sick Children. He has been associated educated at the University of Peshawar, from where he got his bachelor degree in medicine and then obtained his PhD from Karolinska Institute, Sweden. He is a fellow of Royal College of Physicians and fellow of Royal College of Pediatrics and Child Health, American Academy of Pediatrics, and the Pakistan Academy of Sciences. He has a very large team of people working with him. Perhaps in Pakistan and in the community at large is his recent induction as a fellow of Royal Society. He's the fourth one in the country, and he's certainly among the giants of science in Pakistan. Dr. Guta has made seminal contribution in the field of pediatric health and maternal and child health. His contributions in terms of research publications are phenomenal. He's one of the most well-known and well-recognized contributors in this field. He has published 8 books and 102 book chapters and over 1,000 index publications. I think the most important one is that 200 of his publications are in world's leading journal Lancet, and his H index is 159, certainly the highest in the country and also among the highest in the world. His work has been cited over 170,000 times, and he's ranked among the top 1% of highly cited researchers globally on the web of science. So through his various appointments and through his contribution both in Pakistan and globally, Dr. Guta has made tremendous contribution. His services has led to many awards and honors. There is a long list of awards and honors. I'm sure you'll be able to find on the website of Tech, but without taking much of your time, let me introduce you to one of the most prominent speakers ComSec can introduce to you, Professor Zulfikar Ali Guta. Professor Guta, please.
Thank you very much, Professor Iqbal, for that really embarrassing and overly long introduction, but thank you very much for your kind words. I'd like to request a couple of things because it's important that we don't have interruption. I can see that there are lots of people who have their mic on. Kindly mute your mics and maybe not have the videos on. We'll have ample time in the discussion. So this is a major area of my work and interest right now, is looking at exactly how the globe is trying to address this existential threat to the world in the form of the first pandemic in over a century to have affected us. And my focus today will be the Islamic world as to how have we done within the subset of countries that represent the Muslim majority countries. Over the next 30 minutes, what I will try and cover is basically some global statistics, talk a little bit about why do we want to focus on this response, what is different about many Muslim majority countries, special considerations. I'll tell you a little bit about the data that we've used for this analysis that's hopefully coming out soon in the Eastern Mediterranean WHO bulletin. We'll talk a little bit about mitigation strategies, because at this stage, one of the biggest challenges in the world in the last 6 months has been principally how do you impose restrictions like lockdowns and how do you get out of those, and what has been the acceptability. It's virtually in the North American hemisphere that I'm speaking from, it's divided populations, divided politicians, and has led to an absolute disaster in terms of of epidemiological pattern of the outbreak. I will devote a significant chunk of time to my dearest home country. We're celebrating our National Day tomorrow, Independence Day. But it's important to see how Pakistan fared with this crisis that came out of nowhere, was not on anybody's budget books, was not on any scientific research horizon. And how did we as a community rise to the challenge, not just from the government, from civic society also. So I will present some data on Pakistan in some detail, and then talk a little bit about where we are going. So let me start by saying that I'm not joking when I say this is an existential threat to the world. These are the Hopkins dashboard data from this morning. I looked at it, and the world has got over 20.5 million cases by now, and close to 750,000 deaths. Now that's an unbelievable figure, because we will, before the end of this year, hit 1 million. And as you can imagine, by definition, this pandemic has affected every geography, even places where we have very little data from. If you look at how information is available, clearly if you're rich, as you reflected on the x-axis here, if you have high GDP per capita and therefore can afford to test a large proportion of your population, like Qatar here, like United Arab Emirates, then clearly your proportion of tests per unit population would be much higher. So here, in terms of global inequity in testing availability, you see a clear gradient where the poor countries who could not afford to spend as much money as rich countries could not afford a large level of population-based testing. Pakistan hasn't done badly, but again, remember that if you look at testing in Pakistan, between March and now, we have spent over $20 million alone in testing within the public sector, not to count about private sector costs. In terms of mortality, again, you see that this virus does not discriminate. And if anything, its bulk of impact so far has been in high-income countries because the data are there. We suspect that the number of cases and mortality due to COVID in low middle-income countries is higher than what is reflected here. So Africa is just a sliver. But as I said, Africa is hardly testing anything. So there are probably many deaths there we don't even know whether they're related to COVID-19. Similarly, in Pakistan, which is here, we suspect that the number of cases and perhaps attributable deaths are lower than what the reality is, but at least we have some data. Many countries don't even have that data. So the next big question is, within the study of COVID-19, why focus on the Islamic world? Is there anything special in relation to these countries that we ought to be looking at? So the first point in that is that these countries are indeed geospatially, geographically, politically distinct. Just take our region, where we are, the stands here, Pakistan, Afghanistan, Uzbekistan, Tajikistan, Kyrgyzstan. These are all Muslim majority or Muslim countries. They all reflect one geopolitical zone and geographic contiguity. Similarly, the Middle East, I don't have to tell you, the Gulf region, Iran, Turkey, these regions represent population movements and geographic clustering, which is again also notable in parts of the Islamic world, which are in Middle East and North Africa. So there are cogent geographic reasons as to why Muslim majority countries may have some unique attributes and also some protective factors. So geographic and geopolitical clustering I've just mentioned, I mean, it does protect them at times and also exposes them. There are also common protective sociocultural practices. So Muslims who have ablution for prayers 5 times a day do have standards of water sanitation, hygiene, utilization, which are different. Dietary restrictions, remember this outbreak started in China, in a food market where people eat all kinds of things. So here, with our dietary restrictions, we do have some level of protection against consumption of agents which might be risk for infectious diseases. And then, of course, in Islam, communicable diseases, prevention, and following edicts is a very fundamental principle of our practice. So there are protective factors in our population that would be different. There are also risk factors, enhanced risks that may be related to communal practices and behaviors. When this pandemic started, we were very concerned about what might happen if people continue to go to Friday prayers in droves, that we do. Very soon after that, we had Ramadan. And in Ramadan, we have communal prayers in the evening and then the celebrations at the end of Ramadan. So, and also the planned religious ijtimas. And as you know, at least in Pakistan and in Bangladesh, these were major factors in the initial spread of the virus because protective strategies had not been implemented to that extent. And I'll come in the end to the whole issue of Umrah and Hajj. The Islamic world has also got pockets and areas of conflict and insecurity where implementation of protocols is very limited, and there may be additional risks. Vaccine hesitancy, and that relates also to preventive practices. Remember, all the limited and remaining pockets of polio are in Islamic countries. In Pakistan, Afghanistan, and Nigeria has only just got out of this in its north. And then there are some gender norms and practices that always concern people when it comes to public health measures. And they relate to issues of participation of women and also empowerment. So the Islamic world has been an area of great interest of my own team. We work extensively across various countries, and more recently, we've been looking at maternal child health in the Islamic world and whether or not there are characteristics that are very specific to this region. And this is a paper that we published on this in the Lancet last year. If you look at the data that we had, there's some very interesting things that come out, because this region is not as universally poor as many parts of Africa, and Muslim majority countries also have some very rich countries in between. So if you look at annual reduction of child mortality between 1990 and 2015 in the Islamic world, the Muslim majority countries here, you will very clearly see a major gradient. So you have countries that have done fantastically, Iran, Turkey, Egypt, and you have others that have had some middling performance, and some which are really lagging behind in the Millennium Development Goals. So tremendous heterogeneity. When you see overall in child mortality trends between Muslim majority countries and non-Muslim countries, there is not a lot to choose. And if anything, Muslim countries have been better overall than many non-Muslim low middle income countries that are used for comparison. So not too bad. However, just look at what's happened to maternal mortality. And here it's the very opposite of what I showed you with child mortality, that maternal mortality rates are significantly higher in Muslim majority countries for reasons that are not very clear, because the same reasons don't apply to child mortality. So do you believe that some of this is related to social cultural practices? And if you look at coverage of care for maternal child health across the Islamic world, each one of these black dots is the country, and the bars here are the coverage rates, medians. You will find that certainly for reproductive health, pregnancy care, we could be a lot better than what we are. So there are some cogent reasons why one should focus on many of these countries that I'm calling Muslim majority countries for specific characteristics. We see this reflected also in the Sustainable Development Goals. This is our recent analysis of how countries are achieving and implementing Sustainable Development Goals across the Islamic world. And as you can see, clearly, there is a north-south gradient that you see reflected here, with many Asian, South Asian, and African countries falling way behind in the Sustainable Development Goal Index. So we needed to look at this objectively, and we needed to look at this through the lens of scientific inquiry. So I'm going to share a couple of slides on methodology. And once again, because there is a lot of noise on the line, can I request people to mute their mics, please? Because we're getting a lot of interference. So we used a number of data sources in Muslim majority countries. The data were from standardized global dashboards like Johns Hopkins University's case counts. We also used the Oxford response tracker for stringency, which is how did government policies get implemented, particularly around lockdowns and restriction of movements. We've also had access to ACAPS, government measures data sets, for many policies that were implemented in the early stages of COVID-19, and I'll share with those. And then, of course, we had a ranking of many of these countries on the basis of participatory democracy from the Economist Intelligence Unit, which is a standardized measure used. For the first part of our analysis, we also had access to Google mobility data on population movements. So we were able to collate a lot of this from standardized international data sets, and then use this for estimating several things that I will share with you. And I can't share everything, but I'll try and focus on a few things. So estimation of case load per data per population unit, the implementation of stringency in terms of non-pharmacological interventions, namely calm downs, physical distancing, lockdowns, physical distancing, and use of masks, etc. We also ranked these majority countries into democracy rankings, and we'll give you some analysis as to whether or not democratic decision making had a role to play. There is a notion, because many of the early countries that were affected by COVID and responded, like China, Vietnam, and a few others, the thought was that the more authoritarian a regime, the more strict the implementation, the better the outcomes, and therefore perhaps democratic processes were not necessarily related to the adequacy of response. And we certainly seem to see that in some of the Western democracies. that many countries in Europe, notably United Kingdom and the United States, have really not done as well as you would imagine, but others have. So let me move on to some of the results. So firstly, when you look at the caseload per million populations, enormous diversity, and you see that diversity within the region. Clearly, this is reflected by the number of people tested. So if you have very little testing, as in parts of Africa here, and I'm notably looking at Somalia, Yemen has virtually no testing. These are conflict areas. You have very low caseload per million population. So this is an anomaly, which is largely reflective of the frequency of testing. But we really generally don't have the same inadequacies around deaths. So when you look at mortality rates and deaths per million population, these are data as of 1st of August. There are many countries where there has been a disproportionately high burden of mortality. And Turkey and Iran are two examples of countries which had early outbreaks and had a disproportionate number of deaths. And I'll come to some of those specificities shortly. In general, like many other countries, Muslim majority countries moved through the policy implementation in a very sequential manner. Many people started with movement restrictions, which are implemented in almost all countries, public health measures, social distancing, and as you go to these things like socioeconomic measures, social physical distancing, and lockdowns, the proportion of countries affected goes down. So only about 14% of all Muslim majority countries were able to implement strict lockdowns, which are virtually curfew-like situations with no population movement. We looked at this graphically with both mean days and 95% confidence intervals in terms of the time it took between the declaration by WHO on March 11th of a global pandemic, which is this broken line here, and how many countries had implemented and to what extent did they follow that declaration of the pandemic. So as you will see, many countries actually instituted travel restrictions and documentation of cases, actually even prior to WHO declaring the pandemic. But in other instances, it took some time, and border closures and surveillance travel restrictions on an average took about 3 weeks before they were implemented in Asia. So when you take movement restrictions, public health measures, social distancing, socioeconomic measures of mitigation, such as giving people money like we have done in Pakistan who have been thrown out jobs, and strict lockdowns, it took on an average about 2 to 3 weeks, and it's sometimes nearly a month before these were implemented in countries. So these data show you in aggregate how the Muslim world reacted to this, not with the same level of speed and alacrity as many other places did. This is a graphic representation of the implementation of the Stringency Index, which is basically lockdowns, and how long did it take from the declaration of the pandemic to things stabilizing. And very clearly what you see in these panels reflected on the situation March the 1st, April, May, June, July, and August, that by the beginning of June, end of May, let's say effectively by the end of Ramadan, most of the effective population restrictions and lockdowns had actually taken place. Very little after that. So when you look at stringency of implementation, you also see the variations and the gradients. Some were pretty stringent. You will see Pakistan was quite stringent, less so than Iran, and others, you have tremendous variation in the way they implemented this. I wanted to look at epidemiological patterns, and this is the overall for all Muslim countries. You obviously cannot see this, so I'm going to go through this in region by region. So when you take Southeast Asia, so what you see on these slides is the epidemiological pattern of the outbreak, COVID-19, in terms of cases per million, and the days since they first had their 3 cases per million population. So we have standardized this across countries to give you a shape of the epidemiological curve. And you will see that countries are different. There are those that had an early introduction and were able to flatten it pretty quickly. Malaysia is a notable example. They had within 2 months measures that absolutely led to the entire pandemic slowing down and closing. And there are others where, for example, like Maldives, a very small country, where they are still struggling. They did very well initially, and they now have high rates. And Bangladesh, which has had a steady increase and only just beginning to plateau. So that's Southeast Asia. In Central and West Africa, you also see comparable patterns with some countries not having the same rate of rise than others. And you will notice in here that these are relatively small countries. But I will point out Mali to you is a country which has very strong public health measures because they've had an Ebola exposure that they've been able to flatten and restrict this epidemic curve from rising too rapidly. Our own region, the STANs, Southwest Central Asia, we had quite an early exposure. And you will see Turkey really had a terrible time because they had a rate of rise, and by 2 months, a pretty high steep curve, which looked as if it was going to reach the levels of Italy and other places, but they've been able to bring it down since quite rapidly. Iran, similar pattern, very high early rates of exposure, initial outbreak in Iran in Qom, and then followed by steady increase and yes, the very slow plateauing. So their plateauing is different from that of Turkey. And Pakistan I'll speak about in some detail. The Central Asian states of Kyrgyz, Kazakhstan are now just beginning to see a second upsurge, which is a bit surprising because they did so well initially, and that's largely related to imported cases. North Africa, Gulf region in Saudi Arabia, and here it's an interesting comparison because they all seem to be very similar. So whether it's Saudi, Qatar, or others, they have had, despite the fact that they've had the access to the highest rate of testing in the region, they have not been able to flatten the curve to the same extent as others. And many of these countries actually do not have complete data on their expatriate population. So this is something worth noticing, that there has been a challenge in terms of keeping this under adequate control, and they're only just beginning to get to that. I wanted to see what patterns could be looked at overall. So this is now all of these countries aggregated into 4 patterns that you begin to see here. And it's quite evident from the shape of the curve. So if you look very early on in the first couple of months of the outbreak, we have 2 patterns. We have those that had a very early outbreak, rapid rise, the ones in these 2 colors, and those that really took their time and what I'm calling late. So you can see the separation of these 2 curves. But then as you move on, you find that those who had early outbreaks, also some were able to flatten this and others could not. And here the same way. So we divided it into 4 groups for comparison. Early outbreak but small, early but large, and then late in a similar manner, to see if there were differences in the way their early mitigation strategies had been implemented. Some way of looking at that is through statistical lens, and these are data till the implementation of the entire stringency measures, early June. Look at this as after Ramadan and Eid. And very interestingly, we don't see a relationship between draconian measures or authoritarian regimen, which we are now lumping as those where the democracy index was lowest, and cases per million population. In fact, it looks like the 13 most democratic states in the Islamic world actually did very well. And this has something to do with maybe community and population interaction, because their mean doubling time of the outbreak was almost twice that of the least democratic countries. And this means that they were able to keep the epidemic under control. And you also see this reflected in the difference between countries that had implemented strict movement restrictions early and later. So there is a relationship between implementation of these interventions through a participatory democratic engagement and through draconian measures, which I think the data very clearly indicate that you have to have participation and community buy-in for these measures to be successful. So countries that were able to do both of those through a democratic process of engaging and then implementing movement restrictions early were able to reduce their caseload quite significantly compared to the others who did not. But this disappears over time. And over time, as populations become more aware, and you can see that these two differences that I'm telling you between the early implementers and the late implementers, this differences in curves that you notice up to 2 months eventually becomes normalized. So you don't see by now the same pattern because people are becoming comparable, but that does not take away from the fact that a lot of the early mortality was clustered here. So it's important to notice that many of those early deaths in many Islamic countries could have been avoided had everybody been able to implement this. So we don't see this now as of August, but that does not mean that the difference was not there at critical time points. What about Pakistan? So we were challenged very early on because nobody was even aware. Everybody was looking at Wuhan in China in terms of our students and people traveling between China and Pakistan. And people forgot that there is a tremendous amount of land movement of Zaireen and religious visits between Pakistan and Iran. And as a result, before long, it became clear that these people were coming in from Taftan in general, and that they posed an enormous risk of spreading. So this is very early on. So I'm going to show you these district-specific data that have not as yet been generated for Pakistan. So these are actual data in terms of cases per million population. In the early parts of the epidemic in early March, you see that it had already begun to spread, largely through these Zaireen coming in to parts of southern Punjab, parts of northern Sindh, and parts of KP. And then by the middle of April, the spread is a bit more remarkable. By that time, the National Command and Operations Center had begun to also gather data on mortality. And I must commend and compliment Faisal Sultan, who led that process in terms of collating some of this information with the help of people on the data collection side and the NDMA. And you begin to see by early May, at the outset of Ramadan, that we are almost infecting, in terms of cases, the entire country, with the exception of few districts here we had little data from, and that the case fatality rates are beginning to appear. KP had some of the highest earlier burden. Some of these were people returning from the Ijtama and Rai wind, and it was a bit difficult to implement strategies, but there was also lack of adequate health preparedness in the health system. By the middle of May, you see this pattern become a bit more established. By the end of May, quite clear in terms of the districts being affected, so on and so forth. And here we come now to August. We haven't collected any data from mid-July onwards by districts, but as you can see, almost every district in the country has been affected. And there are some pockets where we don't have a lot of information, and that's largely related to data collection systems. So our overall case fatality rates, close to around 6,000 deaths, reflect many of these districts in KP, Punjab, northern, southern Sindh, and virtually affects the entire country. We are, however, much better than many others in our region. These are comparisons of 3-day rolling averages between South Asian countries. India is still on a major upsurge, but if you look at the clustering of cases here, Pakistan, Bangladesh, Afghanistan seem to have flattened the curve in terms of cases as well as case fatalities. This is more specific data from February, end of February to 4th August. And the blue line that you see over here is the total number of cases on a regular basis. And what you see quite clear here is in relation to many of the mitigation measures, we are indeed beginning to see a reduction in local transmission based on this data. Overall case positivity rates are around 4%, and they are generally been stable at around that level. When you look at provincial comparisons, Punjab and Sindh have borne the bulk of the cases. KP overall, in terms of positivity rates, has been lower, but there's also the question of why testing rates have also been specifically lower in KP. If you look at trends, as I've mentioned, again, amongst daily tests and positive samples, overall positivity rates, as I said, are averaging around 4%. And you can see this very clearly here. Our peak at one stage was around 15, 16, 17%. That was in the month of June. And that's all gone down to levels which are less than 5%. And it's something that we need to continue to track. These are deaths. And as you can see over here, around the 6,000 deaths. Our 11-day average now for the last 10 days or so is around 20 deaths. Our maximum peak was around 100, which was also in the month of June. So I don't think you can hide deaths. So generally, it looks like severity of illness related to COVID has gone down a fair bit in Pakistan. And alhamdulillah, if it remains well for the next 2 to 3 weeks while we pass through the exposures in Eid al-Adha and Muharram, then I think we might be able to say that we've been able to get over this effectively. This is just the number of tests and people who've recovered. So of course, those who recover, with the cumulative number will go up, but our testing rates are modest. In terms of critical hospital load, this was the major reason why the NCOC was set up, is to look at the balance of resources in our health system and how we could cope with severe cases, hospitalizations, ICU care, ventilation. There was a lot of brouhaha on ventilation. And as people realize with improved case management that ventilation is only one component of handling COVID, and that a lot can be done with less intensive regimes of oxygen therapy, CPAP, and prone positioning and other measures in hospital, that the requirement for ventilation has gone down. But Pakistan is now self-sufficient in terms of ventilation needs for COVID. I wish I could say the same for children. We have an enormous need for respiratory care for newborn infants and young infants. And hopefully some of this experience in Pakistan of trying to provide intensive care for something like COVID will help us in rebuilding our health systems as we improve. Interesting data on age and gender distribution. As you can see, the majority of cases are almost 3/4 are under 50 years of age. That reflects our young population. That could also be a reflection of why case fatality rates have been lower. And about 3/4 of our deaths are in older individuals above 50 years of age. Here in the West, this would be a cutoff at around 65, but we are using a cutoff of 50. I want you to see that it's not that there aren't any deaths in pediatric age population under 20, that we do have some deaths. But the other interesting thing here that we don't have a good handle on is this very clear gender differential. A lot more male patients than females, and a lot more deaths amongst men than in women. And this could be a biological difference, but it would also be a difference of, as I said, in less women coming to hospitals when they are symptomatic or seeking care when they fall ill. So it's something that we need to parse out through in our data as we go forwards. So the big question as I come towards the end of my presentation is, where are we going? What is the future of this pandemic? And if one had a crystal ball, you could tell this with certainty, but we don't have a crystal ball. So we have to rely on scientific inquiry and on prediction on the basis of modeling, which is both at times exact and at times inexact. So if you look at how the curve has gone in Pakistan, this is overall on the basis of weekly averages of cases as to what's happened with confirmed COVID-19 cases. But you will notice that in the policy horizon, all of this has not been an easy one-way traffic. The elements that are in red here are the difficulties that we had to resolve in terms of negotiating with people like the ulama in ensuring that people realized how important it is not to have religious gatherings to the same extent as we would have had normally. And although people took their time to agree, overall, they did agree towards the end, and it has had some impact. So Eid al-Adha has been a lot better than Eid al-Fitr, but still, it could have been a lot better in terms of people recognizing the risks of getting together in large numbers. And I hope that this will also be the case in Muharram. You will also notice that in many things, we also unfortunately had this political diatribe between the Federation and the provinces around lack of agreement on what needs to be done. At times, it was not based on science. At times, it was just based on political differences. But be that as it may, all of those pluses and minuses, we ended up still by flattening the curve, which is a big credit to both the federal and provincial governments here. If Saudi Arabia can control without a major upheaval, uproar, and pushback across the Islamic world, one of our biggest religious annual gatherings, and get people to do this in an orderly manner, there is no reason over the next little while, and I'll talk about how long, that we could not and should not be able to implement many of these mitigation measures at scale in order to reduce risk of population transmission of the virus. So what further research is needed? As I said, modeling, extremely important for us to know where this epidemic is going. And we've done it for Pakistan. I'm doing it for South Asia. I've not yet seen a model across the Islamic world per se, and we will turn our attention to that if there is sufficient interest across the region, and maybe COMSTEC could play a role in this also. So these are some recent data from Karachi, just hot off the field, which I'm sharing with you. So one important thing for us to note was what's really happened to immunity? What's happened to seroprevalence of antibodies? And although many of these are inexact, these are the first data from a population-based sample, a representative population sample from the city of Karachi, 20+ million people. You can see the sampling units here. And our first data from Karachi across various age strata, under 5 and adults, indicate that we've got close to around 30% seropositivity. So this is reassuring, and it could also explain to some extent why we've been able to flatten the curve to the extent that we have. Remember, in New York, in Queens, at the peak of the epidemic, the positivity rates there were around 40%. So we are not too far behind, and we would need to continue to track this as we will over time. We've fed some of this data into our modeling strategies, both in the basis of current coverage of interventions as to where is this epidemic going. And these are 3 models that we have right now. One from the Institute of Health Metrics and Evaluation in terms of their projections, in terms of numbers. The infamous Imperial College projection is not here of a lot of the lower limit of what they projected as deaths is here, because they had projected almost 1 million deaths. And here is our model at the top of where we think we might be going with various measures. All of these concur on the one thing that I want to show you, which is that we are going to have to live with this epidemic or pandemic for many, many months to come. And the prediction currently is that things may stabilize with this in the background, and it will go till definitely the beginning of 2021, and maybe towards the end of 2021, once people begin to learn how to live with this virus, how to implement many of these non-pharmacological interventions, and potentially vaccine availability. So I'd like to conclude, Mr. Chairman, ladies and gentlemen, by saying that this is indeed a once-in-a-lifetime global challenge. The last such global pandemic was over a century ago with the great influenza pandemic. And despite much efforts and really an enormous global collaborative effort on the science, many of the factors involved in the pathogenesis, risk factors, and epidemiology of COVID-19 is still incomplete. And therefore, whatever I say or anybody says has to be tempered with a touch of humility around how little we know about some of these things. So we have to keep our eyes open and our spirit of inquiry open. The virus is very unlikely to disappear, irrespective of what many politicians say. And this pandemic is likely to persist well into 2021, possibly 2022. These epidemiological patterns will depend upon a range of host and pathogen factors, as well as potential availability of an effective vaccine when we have it. So let's watch this space and learn how to live with this. Most Muslim majority countries have avoided the large-scale catastrophic outbreaks that were the hallmark of the outbreak in Europe and in the United States. And the reality is that this could be related to very specific attributes, such as relatively younger population in much of the Islamic world. Certainly in the Middle East and in our country, half of our population is young by definition. There could also be factors related to innate immunity, prior exposure to other coronaviruses, and also population uptake of mitigation strategies, whether we like it or not, has not been as bad as people thought it would. Pakistan has been also a very remarkable global example, in fact, one of the best in low and middle income countries, of how a data-driven, well-coordinated response has been there and has led to a difference. And I believe, and I want to end with thanking Comstack for inviting me to present to you that there is a clear role of science bodies in the Islamic world, Comstack being at one of the apex ones, of trying to now put some scientific effort into helping us overcome this big global challenge. Thank you very much for your attention, and I'll be very happy to answer questions.
Thank you very much, Professor Guta. It's absolutely fascinating presentation with extremely interesting statistics and very critical analysis of the situation yesterday, today, and tomorrow. Your presentation has actually touched many aspects of it in a very critical manner. Some of the aspects which we have never thought about, from literally from deployment of science to religious practices, everything has influenced what has happened in the Muslim world and in broader sense in the rest of the world also. I think the most important outcome of your presentation, as I can see, as a great scientist, you said very rightly how little we know about this pandemic and how much we have to learn from this situation, have to prepare ourselves for the future. And also what you said is also very, very important that we have to live with it. Perhaps this pandemic and then many pandemics which will come later. So this excellent presentation would be followed by questions and answers. So please, we have a few questions in chat box, but the other audience are also invited to kindly present your question to Professor Zulfikar Bhutta.
Maybe I can start by looking at what's in the chat box, given that we only have 15 minutes left and I have to leave at 10 o'clock. So is there any possibility that COVID-19 could reappear? I don't think COVID-19 has disappeared. It is very much there. And I think as I mentioned very clearly, we need to learn how to live with it. And we need to learn how to implement measures that are based on very strategic focused targeting. So remember, the Prime Minister keeps talking about what's called smart lockdowns. Smart lockdowns have been pioneered in some ways in Pakistan. United States failed to implement it, which is basically making sure that your entire populations and cities, but geography.
हमारी तरफ से
Hello. Hello.
I think there is some problem at the speaker side. Sir, are you still with us, Professor Bhutta? We cannot hear you, sir. Our speaker is just disconnected. So maybe there is some internet issue with him.
Now we have to wait for him because there are many questions, and I think this presentation has to be followed by a good discussion. So we'll wait for him.
Sure, sir. आए क्या?
I'll take the benefit of this brief interval and tell you that Comstack is in the process of developing a large network of virology laboratories in the OIC countries. And these laboratories would serve as a network for OIC countries. And primarily the objective would be that in various countries, we develop capacity in the diagnosis of viral diseases as well as other infectious diseases. And for that, we have initiated a large program of research fellowships and also inter-laboratory exchanges. We have also submitted a project to Islamic Development Bank, which has been shortlisted as among the top 100 projects out of over 2,000 projects submitted. So what I wanted to inform you that if you are interested in one of these initiatives, please do visit Comstack's website, and you'll find lots of new initiatives related to this pandemic and other capacity building initiatives.
Hello.
Yes, sir.
I'm sorry I got disconnected. I don't know what the heck happened, but I've connected with my handheld device. So sorry if I missed any questions, Dr. Iqbal. Please reread them and I'll answer them quickly.
Professor Guta, I was actually filling in. I was trying to convey that there are many initiatives Comstack has taken, and you have suggested some initiatives also. So there is a question: would everyone? So, is there any possibility that COVID-19 reappear that you have already answered? How many Muslim countries pray in mosque? This is, I think, not so relevant. Is this moving towards the herd immunity regarding COVID-19? This is about Pakistan. So herd immunity in Pakistan is one question, and then I think Professor Jalal from Bangladesh is also has a question. He was trying to present his question. Okay, so Professor Guta, please.
So I think most Muslim countries have some form of communal prayer still going on, but this is with physical distancing. So I think those are varying in terms of practice, but I think you will notice by and large now that the same kind of mass gatherings that we saw in India with the Tablighi Jamaat or in Pakistan with the Ijtima, they are not taking place anymore because everybody realizes that there is a substantial risk involved. I will tell you one thing that I did not elaborate too much on. There was a sense of denial at the very beginning that this is a Western conspiracy, that this virus does not exist, or that this is a conspiracy to get us all into some kind of a vaccine experiment. I think that has died down for good reason, because people can see in front of them that the virus is not imaginary and that the risks are not small. It has killed more people, more professionals than anything recent. I mean, the death rates amongst physicians in many countries, not just Pakistan, India. Right after this, I have to step off in a few minutes because I'm speaking to a group of pediatricians on how they should protect themselves and what is known about this virus. So I think now that everybody knows, what we have to do is to learn how to live with this, as people did in 1918, 1919. Taking precautions, thank God, hand washing, sanitation, face mask use, appropriate face mask use, physical distancing in our households, in our workplaces, and principally learning how to be careful. So I'm hoping that there'll be some benefits, certainly in countries like Pakistan and our region. One of the benefits that I hope to emerge is around reduced risk of diarrheal disorders. When hand hygiene, sanitation, use of sanitizers becomes more widespread, you have lower risk of diarrheal disorders and other infections. This winter, as somebody pointed out, is a big challenge for us because we want to see what happens to other viruses like flu and what happens to other respiratory infections that also go up in the winters, pneumococcal infections, etc. And the use of face masks may also be quite an important one. So I think there may very well be measures that can have secondary benefits. You already have heard how, because of the mitigation strategies, reduced traffic, air pollution levels have gone down in many regions because there are fewer cars on the road, fewer fossil fuel being burned. And that is also true. And I hope that we can maintain that to some extent. So I'm pretty curious to see what will happen this winter in terms of the inevitable rise in air pollution that we have. Thank you. Other questions?
Guta, there is a question which says that why this virus affect less to children through their immunity is not so strong. I mean, children are not on that much risk as expected. This is a
They're not
question
at that much risk of dying. That is true because children have a different immune system from all of us. From what we understand so far, the virus has tremendous consequences for elderly because not of the virus effect, because the immune system goes haywire, reacts a bit too much. In reality, many of those fundamental mechanisms as to why there is age-related difference in how people survive and die is related to the immune system and its capability of responding or not responding. Also, it's a fact that young children have greater exposure to immunizations. One interesting thing that my team has observed, and we published this recently, is this J-shaped relationship within children of adverse outcomes. So if you look at case fatality or severe illness, seems to be higher in young infants and then in adolescents. And in the middle childhood, you have very little. And the major difference is, you have very little immunizations in very young infants, newborns. And by the time you reach adolescence, some of that effect is worn off. So there could very well be some secondary immunity effect. Anyway, if someone is asked this question as a pediatrician, join the session in a bit on exactly these issues for South Asia.
Is there anyone from the audience? I'm sure there are many, but Professor Guta has to leave in the next 4 minutes. So please go ahead if you have any question.
I have one question.
Please. Go ahead.
Thank you very much, Professor Guta. What is your comments about the development of vaccine for prevention of COVID-19?
Well, there's a lot of research going on pharmacological measures. And as you know, many of the drugs have been repurposed. Remdesivir is one of those that is being used, for severe cases. Dexamethasone, an old agent that has been programmed for use in very severe cases, hospitalized ICU cases. And there is research needed for more. But, general history of antiviral drugs, with a few exceptions such as hepatitis C, has been mixed. We only have now got effective combination therapy for HIV, which is antivirals. So I think the Gates Foundation, the Wellcome Trust, many others are investing a lot of resources. The industry is investing a lot of resources on looking at what kind of drug panels can they see. Tremendous scope for research on this. In Professor Iqbal Chaudhry's own institution, I'm sure there is work ongoing and looking at indigenous sources of pharmacological products that may be used either of plant origin or other origins that could be used for this. Remember, the whole thing around chloroquine came out of the notion that there may be some traditional antimalarials that can have antiviral properties. So I'm hopeful that we'll have more products as we go along.
Thank you.
Okay, Professor, I'm extremely grateful. What a fascinating presentation. And
thank you very much for the opportunity, and thank you for giving this topic an appropriate slot in your schedule. Thank you.
Thank you very much, sir. Thank you, everyone, joining this afternoon for an excellent presentation. And thank you, Dr. Guta. Thank you very much.
Thank you so much, everyone. And just for a recall, if you are interested to listen this lecture, the recording will be available on the Comstek website. And if any one of you is interested to obtain the e-certificate of this lecture, kindly contact my colleague, Ms. Khazima at Comstek. Her contact details are already with you in the invitation, and you can obtain them from the Comstek website as well.